Okay, to continue our discussion, I did mention that your FiO2 means, sorry, your FiO2 means your fraction of inspired oxygen. And for patients who have your oxygenation problems, especially those which are not responsive to your usual oxygen therapy, such as your face mask, your nasal cannula, and your non-invasive therapy, your high FiO2 might only be delivered through this one. You have your endotracheal intubation with the help of your mechanical ventilation. So this is your AT tube. This is your laryngoscope. And what your endotracheal tube is going to be doing will be coursing, or will directing that high FiO2 from your oxygen tank to be delivered directly onto your bronchial airways so that the FiO2 will actually reach your lung tissues. Okay? So that there would be proper gas exchange that's actually going to happen. So hence we have your invasive therapy or invasive oxygenation mode of delivery via your endotracheal intubation. And this is how it's actually done. Now, why do we have your mechanical ventilation here is that obviously your oxygen needs to be forcefully um, delivered into your patient. Now, you do not have your atmospheric pressure or even your own respiratory muscles to inhale and exhale. So technically, that's where your mechanical ventilation comes in. It's going to be working like your artificial lungs, okay, because for this particular reason, your the ventilation um, ability of your lungs of a patient who has your pneumonia is not that appropriate, or it cannot accommodate, okay, that particular high flow and to be administered to your lung tissues. So hence you have your mechanical ventilation to help you with that specific problem. Okay, so that's your respiratory support. Without your AT, without your mechanical ventilation, your patient might be going on to your respiratory distress or even your respiratory failure. We don't want that to happen to your patient. Medical management, okay? If in any case you have, again, your problems with your oxygenation, which is non-responsive to your non-invasive methods, then it is very important that your goal is to treat your lung collapse or your lung atelectasis. Also, it is important that you have to have your management for your pleural effusion. Now, if in your pericardial effusion you have your cardiac tamponade, your pleural effusion may likely be resolved using your CTT, okay? Or we call it your chest tube thoracotomy or chest tube thoracostomy. They are likely the same. From the term otomy, it means opening. So what they're going to do is they're going to put an incision on that part of your pleural cavity which needs to be drained. Similarly, di ba, effusion, pag sinabi nating effusion, it's your accumulation of your fluids in your pleural cavity, in your pleural space, causing you to have the restriction of your lungs to actually expand, right? And when we say lung expansion, it means accumulating as much oxygen as you can so that you will have proper gas exchange. But for a patient who has your pneumonia, that can't happen, or there's difficulty of acquiring that or doing that one because of the presence of your pleural effusion. So since may tubig ang bagay niya, or there are secretions, so much of the secretions in your pleural space, what you need to do is to have your attempt at reducing that certain amount of fluids, from your patient's lung fields. Okay, well, with your thoracynthesis, you have that temporary and very, very short or rapid management. Sometimes it might help the patient, sometimes you need to continuously do it. But there's a high chance that if you are frequently going to do your thoracynthesis, this might cause you to have more infectious process, to actually happen. It will put your patient at risk for your infection. Okay, but in a patient who has your pneumonia already, you cannot have your thoracynthesis anymore. Why? Because there's already infection ongoing there. So in order for us not to have any additional super infection or even another opportunistic infection to set in, we might as well use your CTT. Okay, this is to facilitate the drainage of those accumulated fluids in your pleural cavity. So, as a homework, okay, this is going to be your homework for tomorrow. What is CTT and what are the different types of your CTT? Okay, what is your CTT, and there are different types. Your bottle system of your CTT. Actually, in the Philippines, well, there's still not much of an upgrade of your CTT in the Philippines. However, in Western countries, there's no more bottle system for your CTT. What we have though is your plurivac or your plurivac. So you are going to research on this one and your bottle system of your CTT so that you will understand why this is very much important. Okay, especially that these are treatment options for patients who have your respiratory problems and having these complications. So that's for your pleural effusion. For shock, well, obviously, because there is a decrease in your perfusion, um, oxygenated blood to your lung tissues. As a result of that infectious process, your patient might result or might actually um, have a complication such as shock, such as also your respiratory failure, or even superinfection. Ito yung sinasabi ko kanina, superinfection, okay, which is basically the same as when we say an opportunistic infection. It's an infection over another infection. Parang, ano to, uh, double jeopardy para sa pasyente natin. Okay? So these are the things that you need to actually take into consideration. In the long run, what is more important here is that prevention is better than cure. So before you spend a lot of money for the medical management and all other types of management, you can all together avoid these costs or confinement in the hospital if you could go and get yourself have a shot with your pneumococcal vaccination is very important. In many different countries, especially in Western countries, they are very particular about having your vaccines or your shots, your pneumococcal vaccine shots. Um, pero since mahal kasi ito, if I'm not mistaken, parang 1,000 plus ang isang shot every year. Okay, itong pneumococcal vaccines natin. For those who go out of the country or maybe work in other countries, you cannot leave the Philippines and work in another country unless you have all of your shots, and this one would be included in those shots. Okay, high risk, as I mentioned, the high risk population are you're very young and you're very very old. So, yan. At saka, of course, kung ikaw ay immunocompromised, dapat meron ka ding pneumococcal na vaccines. Okay? So, that's it. Nursing management. Sabi ko nga, ang pinaka-importante dito is that you provide what is missing And hence, if you want to have your oxygenation, you must improve your airway patency. Maraming laman, or if there's a lot of your secretions in your bronchial airways, then you have to do something about that. Your nursing diagnosis would be your ineffective airway clearance. So what are you going to do with that? You have your postural drainage. You have your deep breathing exercises. You have your coughing exercises. You also have to have your chest physiotherapy. You have to have your bronchodilators for that matter. All of these very important in improving your airway patency. Promoting rest and comfort is very important. Anybody who is actually sick needs to have bed rest, especially if it's viral infection. And you need to conserve your energy because you don't want undue workload on an already failing or on an already very, very sick lung. Okay? Promotion of your fluid intake and maintenance of your nutrition is also very important. A client who is suffering from pneumonia, by the way, is at risk for your dehydration. Paano nangyari yon? Why do we have your dehydration in a client who has your pneumonia? If a patient suffers from pneumonia, remember, you have rising fever there. A client who has a temperature 40, can you imagine? 40 degrees Celsius, centigrade, for that particular instance. You are losing a lot of your fluids there. You call it your insensible fluid loss, wherein because you are having your diaphoresis at the same time, as a result of that fever, you also have your um, yung very warm temperature, regulation is not working appropriately. You lose a lot of this fluid through your insensible fluid loss. And uh, apart from that one, this is going to be continuous, right? Because I'm not just talking about like 1 hour of that insensible fluid loss. I'm talking about the whole freaking day for your dehydration to actually occur. That's why it is important kung tolerated ng pasyente mo na mag increase oral fluid intake, go ahead. That's one of your interventions for the patient who will be suffering from your fluid losses as a result of your infectious process. Okay, so promoting of your fluid intake, unless it's contraindicated and unless it's actually told to you by the physician that no, it's not possible to have your increased oral fluid intake unless your physician tells you that you you are going to promote fluid intake for your patient. In like manner, you also provide your proper nutrition to your patient because he needs your proper nutrients and your supplemental nutrients so that he could recuperate very quickly. Okay, promoting patient's knowledge. So one of the reasons why, or not just your patients, by the way, we're talking about the whole community, like a household, mga neighbors mo. Because that's why we call it your community-acquired pneumonia, right? Because the transmission is within people who know or who live with each other. Now, if you are able to instill in the minds of these people or of this neighborhood or these relatives the importance of trying to distance yourself during periods of acute infection of these patients, then you could actually help others not acquire the disease or not transmit the disease. So it is important that we have your appropriate knowledge dissemination to individuals so that we could protect more people and avoid the spread of your infection. Monitoring and preventing potential complications, it's important that we are able to identify those signs and symptoms that I have mentioned about earlier, yung mga complications natin. We need to monitor these responses of the patient to our physician. Okay? Because complications would be a huge difference in the manner of our taking care of our patients. It's important that our our patient's situation do not degrade or it does not deteriorate. That's very, very important. I have mentioned and I have told you several times earlier that um, there are people who die of pneumonia because it was too late already. They could not, I mean, the patient is unable to respond anymore to treatment because, well, the the condition was already very severe. Okay, so that's why before any complications happen, or even before the disease actually happen, go get yourself a shot of the vaccine. Okay, so that's the nursing focus for our management of patients who have your pneumonia. Okay, now let's move on to your other condition. We call it your acute respiratory distress syndrome. So it's in short, it's your ARDS. I am pangit at hindi siya. Let me erase that one and change it to a better. Yan. Dito tayo, it's your ARDS. Yan. Ang ARDS, they say, is, ano siya, um, it's a condition under your respiratory failure or vice versa. Basta kapag meron kang sinabi na respiratory failure or even your ARDS, they have likely the same type of, they have likely the same type of manifestations and even your interventions. Okay? So definition, it's a severe form of acute lung injury. The term lung injury. Okay? Severe form of acute type of lung injury. Now, there are many different ways on how we have your lung injury. You can have your lung injury kasi nga meron infections process, or you can have lung injury because of your chest trauma, or because of your flailed chest, or when you have your vehicular accident. But this one here, your acute respiratory distress syndrome, when we say, by the way, syndrome, again, it's a it's a group or a collective term for a group of signs and symptoms without a specific treatment. I mean, without specific cure. Okay, without a specific cure. Now, let's go to your definition. It's a clinical syndrome characterized by a sudden, so that's very, very fast, and progressive pulmonary edema. Imagine mo that the whole of your lungs in both left and right has your pulmonary edema. And I'm talking about progressive pulmonary edema. I'm not just talking about your inflammation in your bronchial airways, or maybe inflammation in your bronchioles, or maybe hyperinflation or inflammation of your alveoli. I'm talking about an extensive inflammation of both of your lungs in your left and your right. Okay? There's increasing bilateral infiltrates on your chest x-ray. And you also have your refractory hypoxemia. The definition of your hypoxemia is that, ayan o, emia means blood. And you have your hypo, which means down, and ox, which means oxygen. So if you're going to take this one and put it back together, since we have already dissected each of segments of this particular word, what it means is that there is a drop of oxygen in your blood. And when I say refractory hypoxemia, ibig sabihin nun, even if you are provided with high levels of your oxygen, there is still hypoxemia that's occurring in your bloodstream or in your circulation. So no matter how much we are giving you or somebody else is giving you with your oxygen, there is still less amount of that oxygen reaching your tissues because not enough of your oxygen is in your bloodstream. Okay? Absence of an elevated left atrial pressure which facilitates you to have your gas exchange. Okay? That is what's wrong with your acute respiratory distress syndrome. Now, with your ARDS, ito yung acute lung injury natin. Yung onset, sabi ko nga, mabilisan. Acute lung injury, mabilisan. Kasi from the word acute, it's fast, it's rapid, it's now. Okay? Hypoxemia. Ayan. Dapat, pag meron kang normal around more than 400 dapat. But this is even less than 300 millimeter mercury. Um, as far as I know, when we have your FiO2, yung percentage ng oxygen natin or your partial oxygenation pressure is actually like less than less than 300 less than 300, 200 to 300, or even less than 100. It's considered if it's less than 100, it's considered severe. If it's around 300, 200 to 300, it's considered mild, and 200 to 300, no, 100, 200 to, and then 300. Ayan. 100 severe ito. This is like mild, this is like moderate, and this is severe. Okay? Ibig sabihin nun, your fraction of inspired oxygen, the lesser that is circulating in your bloodstream or being distributed into your bloodstream or flowing into your bloodstream, the more severe it is. So once this one reaches like around 100, that's a big problem. Just in your chest x-ray, what do you see? Bilateral infiltrates consistent with your pulmonary edema. You have, it's obviously it's non-cardiac cause because we're talking about your pulmonary problem. So no clinical evidence of the left atrial hypertension. Even if there is your pulmonary edema, diba sometimes with your pulmonary edema, it actually increases your your hypertension, specifically on your pulmonary area. Okay, that's why you have here, pulmonary artery occlusion pressure, which is less than 18 millimeter mercury. 18 or less than 18 millimeter mercury. Now, next we have, since you have ito yung medyo acute lang injury, hindi to masyado, parang kakastart pa lang. Pero kapag, criteria for acute respiratory distress syndrome, we have your hypoxemia, which is now less than 200. Sabi ko kanina, kapag less than 100 yan, mas malaki ang problema mo because it's going to be a severe case scenario. Okay? Bilateral infiltrates, same lang din naman siya, no clinical evidence. But it's basically an ending between your hypoxemia in your acute lung injury and that of your acute respiratory distress syndrome. Okay? Dapat mas mataas yung FiO2 mo para at least ma-distribute pa din yung oxygen mo. However, in this particular syndromes, bumababa siya ng bumababa kasi hindi na kaya. The percentage of oxygen that's going to be delivered or that's circulating is not that efficient anymore. Okay? So, next we have, ayan, ito yung lung injury natin, no? Because, again, there is your initiation of your inflammatory immune response. Ito yung inflammatory immune response. Sabi ko kanina, it's going to be either an infectious process, bacterial or viral. That's where you initiate your inflammatory immune response. Or maybe there was a chest trauma or vehicular accident. All of these are predisposing factors for the initiation of your immune system response. Ayan. Now, pag meron kang pinag-uusapan na inflammatory response, you will always have your chemical mediators. And I did mention this one. Having your chemical mediators means to say there is a release of your cytokines. I hope you can still remember your microbiology or maybe even your biochemistry where there is a discussion of your inflammatory response or even in your anatomy and physiology with your chemical mediator release, which includes your cytokines, yan, yung mga kinins natin, yung ating mga mast cells, yan. Lahat ng mga ito, they are released into the system as a result of that inflammatory immune response. Now, when these are released, these chemical mediators create a cascade of events. And these are the cascade of events that are actually seen. So there is increased capillary permeability, membrane permeability. Ibig sabihin nun, mas yung membrane natin, mas nag-open siya para mas makapasok, or there's your increased leakage of your fluids. Increased leakage of your fluids. Dapat nasa capillary siya, pero since lumaki nga yung butas ng ating membrane, nakalusot siya, which, okay, goes into where? Your alveoli or your alveoli. Now, your alveolar flooding with loss of surfactant technically is an event that happens as a result of your immune system response. Tapos, since palaging nakataas yung immune system response natin, and because there is your inflammatory response as well ongoing, eventually your alveoli cannot take in so much of that flooding of that fluid into its own specific space, because you know your alveoli is specifically for your gas exchange. So again, it inflates and deflates on its own because it needs air only. However, what happens with your acute lung injury is that instead of air trying to get in your alveoli, what do we have here? These are water. These are fluids. These are secretions, causing you to have eventually your alveoli collapse. Okay? Next, in airway, there is a decrease in your bronchiole or even your bronchi diameter, okay? Which causes you to have increased airway resistance. Kasi there is so much need for your oxygen. There's so much need for gas exchange, but it's not going to happen. Because why? Your bronchial airways, the diameter are actually very, very constricted. Okay? And because there is an attempt to actually have as much oxygen and thereby increasing airway resistance, hindi kakayanin kasi wala nga makalusot. So, ang mangyayari dyan, the lung is going to suffer and is going to have a decrease in your lung compliance. And since there is decreased lung compliance, your lung not doing their job appropriately, what happens as a result? You will have your labored breathing, you will have your tachypnea because your body tries to attempt to get as much oxygen but it's not working again. Okay? Hindi walang makalusot kasi nga constricted yung bronchial tsaka bronchial airways mo, hindi ba? Pati yung lungs mo hindi na gumagana kasi wala naman siyang nasasagap na mga oxygen. So, again, labored breathing at the same time, dadagdagan siya ni alveolar collapse. So, you end up having your alveolar hypoventilation. Hindi na nakapag-hyperinflate or hindi na nakapag-inflate si alveoli mo kasi wala siyang makuhang oxygen. Okay? Intrapulmonary shunting as a result of that deoxygenated blood that is actually circulating, hindi nakakapasok doon sa ating lungs. Okay? Therefore, ang ending dyan is your hypoxemia, a decrease in your oxygen in your circulating blood volume. All this, not important. I mean, not everything is not just useless. No matter how much of your oxygen is given, nope, in your blood, there's just not enough oxygenated blood. Okay? Apart from that, you have with the continuous release of your chemical mediators, okay, with the continuous release of your chemical mediators, you have your pulmonary injury to your pulmonary vasculature. Well, we could consider your, sabi ko nga yung chest trauma kanina, like vehicular accident or maybe somebody stabbed you, and doon mismo sa chest wall mo, ayan. Again, inflammatory response ang mangyayari dyan. And then, you will have the cascade of events which will include your pulmonary vasoconstriction, okay? You will have your microemboli formation. You will have your pulmonary hypertension kasi nga, nasugat si lungs. Di ba? Apart from that, because this one is going to continuously happen, walang makakalusot doon sa ating pulmonary artery to enter into your lungs. Kasi pati yan, apektado. Pati doon sa ating lung fields, hindi makakalusot kasi nga, injured yung ating pulmonary vasculature. Capillaries are actually injured. Okay? Causing you to have these three. And because there is your pulmonary hypertension, again, as a result of that attempt of the body to get as much oxygen as it can, eventually, you're going to end up with your alveolar dead space. Kasi pataas ang pataas yung pressure sa loob ng lungs mo. Okay? The pressure in your lung just becomes too high. Considering that there is your pulmonary edema, tama? Okay, when you have your pulmonary edema, there's inflammatory reaction there. You also have your elevated pressure in your lungs. Remember, the pressure in the lungs should be negative pressure because whenever we breathe something or your oxygen actually goes inside our body, that's where you have your positive pressure and then i-release mo lang din naman para maging negative pressure again. But since there is pulmonary hypertension and this goes on and on and on to a patient who has your acute lung injury, eventually what is inside your lungs, okay, you will have your alveolar dead space because there's no gas exchange happening there. Apart from that one, you also have a decrease in your cardiac output, which would tell your body, hoy, kulang na lahat, wala nang oxygen lahat, anong gagawin mo? Kaya yon, you will go back to the concept of your labored breathing. Okay, labored breathing, which is a cycle. Because even if you attempt to breathe in as much as you can, nothing is actually working for you. Nothing is actually um, improving your oxygenation. Because you will eventually have your hypoventilation and then your hypoxemia. Okay? So, paano mo ba makokorekto? Di dapat meron kang, ito pala, I will explain. These are what's happening when we have your inflammatory responses inside your lung tissues. So interstitial and intraalveolar edema and hemorrhage, merong chances na some of your alveoli, because the pressure is just so high already, okay, eventually, pwedeng pumutok po ang ating alveoli. Kasi parang balloon ang alveoli natin, hindi ba? Pwede siyang pumutok. And when you will have your rupture of your alveoli, that's where you have your atelectasis or your lung collapse. Alveolar consolidation, marami pong laman ang ating alveoli na dapat wala naman. And you will also have your intraalveoli hyaline membrane formation kung saan nagkakaroon ng fibrosis doon sa ating alveoli. Hindi na siya stretchable as expected. You will also have your pulmonary surfactant deficiency or your abnormality. Kulang ka ng surfactant cells natin, which facilitates also, how your surface tension in your alveoli should actually contribute sana doon sa pag-stretch ng ating alveoli. Pero since wala na siya, hindi makapag-stretch si alveoli. Kaya matigas yung alveoli mo, useless po si alveoli. Eventually, you will end up having your atelectasis. Okay? So, clinical course, you have your exudative, you have your proliferative, and you have your fibrotic. Pag sinabi natin exudative, ayan, ito yung maraming mga nana-nana, maraming mga lumalabas sa mga secretions, yan. Edematous po ang ating pasyente dito. Proliferative, ibig sabihin ng inflammatory reactions natin, hindi lang sa nasa surface, hanggang doon sa kaloob-looban ng ating alveoli. That's where you have your proliferation actually happening. You also have your fibrotic or your fibrosis, wherein, from the term fibrous tissues, medyo matigas na siya. Yung sinasabi ko kanina na yung alveoli mo, because it lacks your surfactant cells, it doesn't have your enough surface tension to inflate your alveoli anymore. Eventually, that fibrous tissue is going to make your alveoli difficult to inflate and deflate, and you will eventually have yung, alam mo yung naninigas, matigas na bagay, because there is your scarring, okay? There's the proper term. You have that scar formation already in your alveoli. paano ka magkakaroon ng inflation saka deflation ng iyong alveoli kung naging scarred na ang alveoli mo kasi nag-form na siya ng fibrous tissues in your alveoli. So that's what's gonna happen to your alveoli. And as I've mentioned, your alveoli is one of the most important functional units in your lungs. Okay? Radiologic findings, you have your increased opacity or your white lungs, ayan, ground glass appearance. Ito, look at that. Okay? And then, yes. So since your ventilation is not working, you are going to have your supportive therapy for this. As you can see, you have here your basic non-invasive therapy or management of oxygen is not going to be working anymore. This is way worse than your pneumonia, by the way. Kasi nga, ito na yung susunod, ito yung mga complications ng pneumonia mo. You have your invasive mechanical ventilation. This is where your intubation actually is done, and then you have your mechanical ventilator machine to breathe for your patient. You also have your fluid management and also your pharmacologic therapy. Actually, sa totoo lang ha, for any type of your respiratory disorders, pare-pareho lang yung mga interventions nila. It's always to provide your appropriate percentage of your oxygen to your patient, and at the same time provide your medications and then your fluid management. Kung alam mo, if you're familiar already with your oxygenation mode of delivery, you're good to go. Okay? Kasi kapag naintindihan mo na yun, alam mo kung anong susunod na gagawin mo. Pare-pareho lang ang mga interventions for that one. It's always about providing what is missing, and that is your oxygen therapy. Okay? So, here we go. Ito, mechanical ventilation. Kita mo yan, a patient who is in prone position. You think that is very ineffective? No. It facilitates actually your appropriate ventilation for your patient. We understand that for any person who's having difficulty of breathing, we always put them in your upright position for maximum lung expansion. But in this case here, that is for patients who have the ability to ventilate. But for people who do not have that capacity to ventilate, to do your own ventilation or spontaneous ventilation, it's quite very difficult to do. Hence, you have your machine to do that for you. So this is a patient who is in prone position with your mechanical ventilation. Similar, in this particular case, parang mas madali para sa pasyente na maka-recover or maybe to have, facilitation of your positive and expiratory pressure on prone position. Katulad ng mga pasyente na merong COVID. I have a cousin who's confined in the hospital because of your COVID infection. When we were talking to her, she mentions that even with your high Fowler's position, or even with your your usual supine position, she has difficulty of breathing. She was having coughing fits, and she has your standby oxygen. She tried to put on her oxygen, but still she was unable to breathe appropriately or cannot breathe properly. And then my sister, who works as a triage nurse in Manila, mentions that what you should do is to be on prone position because it might actually help you. And then lo and behold, after she was on prone position, sabi niya, oo nga pala ate, nakakahinga na ako. Okay? It has something to do with how anatomical structure actually affects for certain types of individuals. Di naman lahat eh. But it seems as if for COVID-19 patients, mas nakakahinga sila better with your prone position, especially kapag conscious yung pasyente. But for a client who is on your mechanical ventilator, this facilitates your positive and airway expiratory pressure. Okay, ano bang ibig sabihin ng PEEP? Your positive and expiratory pressure is that extra buga. Di ba kapag humihinga tayo, and then we try to inhale and exhale, there's that extra oomph or extra pressure doon sa paghinga natin para maipasok doon sa ating alveoli, para magkaroon ng gas exchange doon sa capillaries malapit sa alveoli. Okay? But hindi tayo gumagamit ng PEEP kasi kaya naman nating huminga with our normal spontaneous ventilation. But a client who is actually on acute respiratory distress syndrome, or maybe even in your acute respiratory failure, wala po silang extra oomph. Kulang na kulang yung pag-ventilate nila. They do not get enough oxygen. Wala pong wala pong tumutulong sa kanila kasi hindi nila kayang huminga ng sarili nila. Kaya meron tayong mechanical ventilation. Meron tayong machine na nagbibigay, it's going to give us that extra pressure so that the FiO2 or the oxygen, your FiO2 or your fraction of inspired oxygen would actually get enough of that air to go and be directed into your alveoli. Hence, you have your use of your positive and expiratory pressure. Okay? That is your positive and expiratory pressure. You also have, di ba sa normal na ventilation natin, for any normal healthy individual, all of these, these terms, tidal volume, respiratory rate, we can do that on our own. We can have our normal respiratory rate. We can have our normal tidal volume. But for people who have your acute respiratory distress syndrome or even acute respiratory failure, wala po silang ganyan. Because the patient cannot ventilate on his own. Imagine that there are so many components of actually breathing and the things that are involved with breathing alone. We think that it's just rise and fall. No, there are so many things going on there. Okay? We also have your inverse ratio ventilation. Pwede pong baliktarin ang expiration kapag sa tingin ng respiratory therapist, mas kailangan ni patient na mas mahaba yung expiration niya or mas maikli yung inspiration niya. Pwede po yung gawin sa mechanical ventilation. The mechanical ventilation can do that for you. Prone ventilation yan. It allows also, sabi ko nga kanina, it's not applicable for all, but there are those who respond well to your prone ventilation, such as this person. And it's also very applicable for patients who have your COVID-19 because it also lessens the possibility for acquiring infection in the hospital, not just for the other patients in the ward or in the unit. Well, actually, sa ER lang naman nagkakaroon ng ganito eh. When we have less of the rooms, okay, this one provides you less possibilities for transmission of your infectious process. Okay, so that is your mechanical ventilation. Now next, what are your pharmacologic treatment? You know that there is pulmonary edema. Kapag merong edema, ano ibibigay natin? It's your corticosteroids. Okay, corticosteroids. Also, under your corticosteroids, you have your glucocorticoids, also an anti-inflammatory medication. Ayan. Surfactant replacement because there's loss of your surfactant. And because there's loss of your surfactant, you need to give what is missing. Para pwede na ulit mag-expand at saka mag-inflate ulit si ating alveoli. Again, without your alveoli working, everything is going to be useless. Okay? It's where your gas exchange actually happens. It's where your capillaries become highly active for your gas exchange to actually happen. Okay? Sedatives are given to our patients because we need to place our patients in a less stressful environment because the more the client is going to be under stress, whether it's because of your infectious process or because of the anxiety caused by unable to breathe properly. Um, you need to at least manage that well. Okay? Kaya mga pasyente namin na naka-mechanical ventilator, well, hindi to actually napapractice all the time ha. But in ideal scenario, yes, when the patient is on mechanical ventilator, dapat nakasedative yung mga pasyente. But for those patients that I have handled in the clinical area, kapag naka-mech vent sila, uh, actually sometimes many of them are actually, ano to, parang unconscious na. Kaya kahit nawala ng sedative, okay lang. Pero sa ibang mga bansa, kailangan merong sedatives para talagang tulog yung pasyente at hindi na magising at hindi ma-shock sila na bakit meron silang tubo ganyan. Okay? Those are your pharmacology treatment. Next, you have your pulmonary embolism. Ito yung sinasabi ko. When we talk about your blood clots, I'm not just talking about this. For example ha, kung ganito kalaki yung ating vein or your blood vessel, I'm not just talking about a clot this big. I am talking about a clot this big. This huge, guys. This extensive. Ganyan kahaba yung embolus natin sa ating pulmonary arteries or pulmonary veins for that matter. Okay? This is not a laughing matter because hindi yung clot na ganito lang. No. Ganito kahaba, guys. Ganito kahaba ang ating embolus. Okay? So this is your pulmonary embolism. Now, definition is the obstruction of one or more pulmonary arteries by a thrombus or a thrombi, usually originating saan? Doon sa veins mo, o di kaya when you had your myocardial infarction, or when you have your dislodgement of your clots in your pulmonary vasculature, but eventually you end up trying to understand that your pulmonary embolism is not this very small. Malaki siya. And mahirap pong maghabol kapag malaki na masyado ang pulmonary embolus natin. Good luck talaga sa pasyente mo. Okay? Predisposing factors, we have what we call your Virchow's triad. Okay? Triad, tatlo. Kasi it's guided by your three manifestations or clinical features of these pulmonary embolism. So we have here your hypercoagulability. When we say hypercoagulability, mabilis ang coagulation, mabilis mag-clot. Merong capacity ang pasyente mo na magkaroon ng very fast coagulation or very fast clotting effect. Next, we have your endothelial wall injury. Okay? Meron kang endothelial wall injury doon sa iyong pulmonary artery